Who should place your bridge? General dentist, prosthodontist, or other specialists? Let's decide. Tooth loss is widespread. Bridges succeed, with 90 to 95% 5-year survival rates and 80 to 90% at 10. Bridges replace tooth gaps using abutments. Provider choice depends on case factors and specialist teamwork. A bridge is a fixed tooth replacement cemented to abutments, unlike crowns or partial dentures. Main bridge types with typical indications. The essentials. Next, meet the providers who place them. Bridges are placed by general dentists and prosthodontists. Periodontists and oral surgeons place implants. Endodontists treat abutments. Prosthodontists add about 3 years focused on planning, material selection, complex bridges, and occlusal risk. These factors guide referrals. Span, abutments, occlusion, aesthetics, surgery, risk. Thanks to SmileCo, details next. Thanks to Green Exterior Remodeling, Charlotte Community Business Improving Home Exteriors, now we'll choose provider. It depends. General dentists excel with simple bridges. Prosthodontists direct complex, multidisciplinary cases and planning. General dentists handle core steps. Prosthodontists manage complex planning. Next, when general dentists are optimal, often best for short spans with sound abutments and balanced occlusion, posterior low aesthetic zones. Specialists next. Prosthodontists lead complex tooth loss, unstable occlusion, anterior aesthetics, abutment challenges, tilted teeth, interdisciplinary reconstructions. Periodontists stabilize disease, lengthen crowns, sculpt pontic sites, manage implants and maintenance. Next, the surgeon's role. Oral surgeons place implants, optimize sites, and coordinate 3D positioning. Next, endodontics for abutment teeth. Endodontists secure abutments, manage disease, assess vitality. Some crowns need endo later, coordinate with lab. With the team assembled, the lab drives success. Materials, CAD/CAM precision, hygiene contours, aesthetic QC. Full coverage retainers support pontics, PFM or zirconia frameworks. Success depends on preparation, connectors. Next, cantilever. Cantilever bridges use one abutment, ideal for light anterior spans. Posterior overload increases failure risk. Maryland bridges bond metal or fiber-reinforced wings to enamel, minimally invasive, less retentive. Implants next. Implant-supported bridges depend on osseointegration and precise 3D placement for balanced occlusal loading across spans. Implant-supported bridges survive most. Tooth-supported close. Resin-bonded lower. Next, common failure mode. Bridges fail from biological and mechanical issues. Implants have complications. Thorough planning follows. Diagnostics next. For bridge planning, compile diagnostics, exam, imaging, occlusion, aesthetics, space, and confirm abutment vitality thoroughly. Choose robust abutments. Crown root ratios and ferrules matter. Auntie's Law Guides. Overall biomechanics rule today. Select guidance to control load, remove pontic interferences, balance support, then plan definitive preparations accordingly. Aim 6 to 10 degrees taper, material-driven reduction, rounded margins. Preserve ferrule, biologic width. Compare bridge materials, PFM, zirconia, and lithium disilicate. Next, we align cementation choices with indication. RMGI for conventional FPDs, adhesive resin for short preps, MDP primers for zirconia. Next, pontics. Pontic choices balance aesthetics and cleaning. Ovate, modified ridge lap, hygienic for posterior zones. Hygiene next. Longevity depends on interdental cleaning, managing caries and dry mouth, guarding bruxism, and routine recalls. Expect brief sensitivity, occlusal refinements, pontic tissue adaptation, plus early review confirming fit. Hygiene status. Case 1. Straightforward posterior bridge. General dentist appropriate. Delivery in weeks. Next, Anterior aesthetics, prosthodontics. High smile lateral loss favors prosthodontist leadership. RBB now, implant later, or FPD considered. 2 molars missing, implant bridge indicated, sinus-aware 3D planning, seamless team coordination. Next, bruxism management. Severe bruxism, posterior loss. Select strong zirconia frameworks, refine occlusion, prescribe night guard. Monitor. Cost coverage next. Typical patient pay costs shown. Bridges often 50% covered after deductible. Annual maximums apply. Timelines next. Typical timelines. Tooth supported 2 to 4 weeks. Implant span months. Resin bonded faster. Digital workflows next. Digital workflows boost accuracy and efficiency. From scanning to CAD CAM and printed guides. To ensure bridge quality, look for clean margins, tight stable contacts, even occlusion, and overall shade harmony with neighbor. Compare bridges, implants, and partials across essentials. Next, we weigh key risks and patient factors. Provider choice accounts for growth, caries risk, systemic factors, and the practicality of long-term maintenance. In short, for bridges, choose general dentists for simple spans, prosthodontists for complex interdisciplinary cases. Here's the mapping. Routine remains general. Advanced becomes prosthodontist-led. Implants need a coordinated team approach. Defined roles align planning, surgery, endodontics, restorative execution, and fabrication. Next, we present longevity determinants. Bridge longevity depends on caries control, ferrule geometry, material load match, precise fit, and regular recalls. Myths corrected. Bridges succeed with ferrule. Implants aren't universally superior. Modern zirconia frameworks are strong. Dental bridges last when biology, occlusion, materials, and hygiene are optimized. Match provider to complexity. Choose the dentist whose expertise matches bridge complexity. General for simple, prosthodontist for complex, implant-based. Choose the right dentist. Matching complexity to expertise ensures lasting, natural results for your bridge.